cells. And the bone marrow is able to compensate for hemolysis up to a certain extent, after which anemia develops. And the onset of hemolysis varies in different conditions. Sometimes it can be massive and spontaneous, and in other situations it is in a slower and goes over a period of time. So this is just an overview of the classification of hemolytic anemias. As you are aware, we have congenital hemolytic anemias, mainly the hemoglobinopathies, the membranopathies, and the enzymopathies. So these are the inherited hemolytic anemias, and I believe those lectures have already been covered. Today, we are going to talk about acquired hemolytic anemias, and the classification of acquired would be based on immune and non-immune causes.
Dr. David?
Yeah.
We were supposed to do the hemostasis.
Oh, you said hemostasis. I thought I had hemolytic. Okay. No. Okay, just give me a few minutes. I go through my lecture. Yeah.
Yes, doctor.
Yeah. I think I read differently.
Sorry
about that. Let me just get the lecture. Yeah.
Okay.
Recording stopped.
Okay, just give me 5 minutes. I download the lecture and screen share.
No problem, doctor.
Okay, sorry about that. We'll talk about acquired disorders of coagulation. Again, when we have coagulation disorders,
Recording in progress.
we have congenital and acquired. Congenital disorders are inherited disorders of the coagulation factors, inherited disorders of platelet function, and others, which I believe have been covered. And I'll talk about acquired disorders, principally disorders of the coagulation pathway. Acquired coagulation disorders are more common than the hereditary disorders, and they are usually secondary to an underlying disorder, which may be hematological or non-hematological. And there are multiple hemostatic defects that are present in this clinical spectrum. So some of the conditions, the acquired conditions of hemostatic disorders include disseminated intravascular coagulation, of which there are a number of causes, severe sepsis, obstetrical causes, and others like snake bites and so forth. Some malignancies as well, disseminated malignancies, and some leukemias like acute promyelocytic leukemia. And then we have liver disease. As you are aware, most of the coagulation factors are synthesized in the liver. And when we have chronic liver disease with imminent liver failure, then there is reduced synthesis of the coagulation factors, and that presents with a coagulopathy. Vitamin K deficiency that we see in neonates and sometimes in adults can also present with bleeding disorder in an acquired bleeding disorder. Of course, drugs are also important. Drugs used as anticoagulants like heparin, warfarin, and other therapeutic agents that we use to dissolve clots. That's thrombolytic therapy, principally used when we have acute myocardial infarction or stroke. And then in certain diseases, when we have paraproteinemias in patients who are on cardiopulmonary bypass, and also when we give patients, especially those who have severe trauma or following transplants, where there is massive blood loss and we are replacing the blood volume, then the coagulation factors get diluted. And as a consequence of that, they may present with a coagulopathy. Now, DIC occurs in a wide spectrum. It accompanies a wide spectrum of underlying diseases. It's seen in a number of disorders. And in this condition, there is systemic activation of coagulation. So the coagulation cascade is activated, but it is of low intensity. So fibrin is formed, but it is cleared from circulation. As a consequence of that, a clot is not formed. The fibrin is degraded. The fibrin is degraded before it forms a clot. But in this process, the coagulation factors get depleted, and it presents with a coagulopathy. Now, in DIC, disseminated intravascular coagulation, the platelets also get consumed. So there is a deficiency of coagulation factors because they are consumed, and the platelets are also consumed, so there is thrombocytopenia. And as a consequence of these two arms of hemostasis being involved, there is diffuse bleeding that takes place. Now, the fibrin which is formed, although it doesn't form a clot, the small strands of fibrin that are formed in the smaller blood vessels will affect the blood flow to those organs, and we get organ damage due to the formation of these microthrombi. Now, there are various causes of DIC. Severe gram-negative infections are top on the list. The gram-negative bacteria, the cell wall of the gram-negative bacteria has the propensity of activating the coagulation cascade. And as a consequence of that, we get DIC. So severe infections, particularly gram-negative infections. Severe trauma also can cause DIC. There is a release of tissue factor in small amounts, which causes activation of the coagulation cascade, and the coagulation factors get consumed. Various malignancies, particularly acute promyelocytic leukemia, which used to be known as AML M3 subtype, acute promyelocytic leukemia. The promyelocytes have granules in them, and these granules can activate the coagulation cascade and cause disseminated coagulopathy. Metastatic carcinomas, some of the carcinomas, breast cancer, cancers arising from the gastrointestinal tract, towards the late stage of the disease, when the cancer cells have embolized into the vascular system, again, the coagulation cascade can be activated and we get a coagulopathy. The other major area where we see disseminated intravascular coagulation is in obstetrics, various types of obstetric complications, amniotic fluid embolism, abruptio placenta, septic abortion, and retained fetus, and also eclampsia, preeclampsia and eclampsia can result in microangiopathy, manifesting as disseminated intravascular coagulation. So I don't know whether you have done your obstetrics rotation, but I think we'll see these all next year. These are important causes of disseminated intravascular coagulation. Then when we have incompatible blood transfusions, resulting in a severe hemolytic transfusion reaction. So incompatible, like a patient who is blood group O receiving A or B blood, or a patient with blood group B receiving A blood, group A blood, they will have a major hemolytic transfusion reaction, which may present as disseminated intravascular coagulation. Extensive burns will also cause disseminated intravascular coagulation. There is damage, tissue damage, there is blood vessel changes because of burns, physical damage to the blood vessels, vasculitis, inflammation of the blood vessels, tissue damage. All that would contribute to activation of the coagulation cascade in a low intensity activation, very low intensity. So presenting as DIC. Snake bites, the poison or the venom of some of the most venomous snakes activates the coagulation cascade and presents with DIC. Then severe liver disease and giant hemangiomas also may present with a disseminated intravascular coagulation. So there is activation of the extrinsic pathway, and there is generation of thrombin and fibrin. And as a consequence of that, the naturally occurring anticoagulants are also depleted. There is suppression of the fibrinolytic system. There is inadequate removal of fibrin, which results in microthrombi and end organ damage. And because of the depletion of the coagulation factors and the platelets, there is diffuse bleeding in the patient. So bleeding from Venipuncture sites, epistaxis, petechiae, and bleeding into the organs that arise because of a combined deficiency of coagulation factors as well as platelets. So it's a life-threatening situation, and it needs to be managed urgently and appropriately. There is also a secondary activation of fibrinolysis, because the fibrin that is formed in the microvasculature has to be removed, and it's degraded, and we get fibrin degradation products which are formed. The smallest molecules of these degradation products are known as the D-dimers, So D-dimers will be increased as a result of fibrinolysis that takes place to remove the fibrin. Some of these degradation products aggravate the bleeding because they inhibit polymerization. And because we have fibrin present in the microvasculature, as the red cells traverse through the microvasculature, the fibrin strands will damage the red cells. So the red cells get sheared because of the fibrin, and fragments are produced, and that is what we see on the peripheral blood film: fragmentation of red cells. So what would be the clinical and laboratory features? Of course, the clinical features will depend on what is causing DIC. So if it's sepsis, there'll be features of sepsis. If it's an obstetrical cause, there is a history that will be elucidated, and a physical finding on examination. So there will be platelets which will be reduced. So there is thrombocytopenia. And as we monitor the patients, we see that the platelet counts are dropping periodically, indicating consumption of the platelets as well. Because the coagulation factors are being depleted, the coagulation parameters in terms of the prothrombin time and the activated partial thromboplastin time will be prolonged. Fibrinogen levels are also reduced because fibrinogen is also being consumed. And the inhibitors are also reduced in plasma. Examination of the peripheral blood will reveal fragmented red cells, which if you can recall from your morphology, fragmented red cells, and we call them schistocytes. The D-dimers and other fibrinogen stroke fibrin degradation products will also be increased. And we used the D-dimer test as one of the parameters in evaluating patients with DIC. And when we are treating these patients, so first and foremost, we have to treat the underlying cause. If it's an infection, gram-negative infection, we need to use broad-spectrum antibiotics, maybe the third, fourth generation cephalosporins, and other more powerful antibiotics that are available for treating sepsis. So treat the underlying cause. If it's infective, one of the commonest reasons that we see DIC is severe infections. Once we start them on the broad spectrum third, fourth generation antibiotics, and we are able to control the infection, then everything reverses and we are able to save the patient. In the interim, as we are treating the underlying cause, we have to replace the coagulation factors, and we also have to replace platelets. So we can give them cryoprecipitate, or more commonly, we give them fresh frozen plasma. And we also need to give them platelet transfusions. These patients are very sick, so because of gram-negative sepsis, they may be in shock, so we need to support the cardiovascular system. They may be in respiratory failure and will require respiratory support. They may require mechanical ventilation. Accompanying renal failure is a frequent finding in patients with severe infections and also in other causes of DIC. So they may require dialysis as well to support them. And we have to maintain their electrolytes and fluid balance. Moving on to liver disease. As I mentioned earlier, the liver is the primary site for the synthesis of most of the coagulation factors. It also requires vitamin K for carboxylation of some of these factors to make them active. And these are the factors that are vitamin K dependent, factor 2, 7, 9, and 10. The liver is also important in clearing activated coagulation factors. So when some of these factors and inhibitors are present, they neutralize. The complexes that are formed are removed in the liver. So there is clearance of activated coagulation factors by the liver. But more importantly, the liver is the site of synthesis of most of the coagulation factors. So what would be the cause of bleeding in liver disease? Okay, so we may have bleeding from esophageal varices when there is portal hypertension. So there's splenomegaly. The splenomegaly, of course, will result in increased pooling of platelets, so there will be thrombocytopenia. Because of deranged liver functions and depleted coagulation factors or diminished coagulation factors due to decreased production. So we have decreased coagulation factors. We have an enlarged spleen, which is pooling the platelets. And because of that, bleeding can be very severe in patients with portal hypertension, bleeding from esophageal varices. Now, in liver disease, again, there is going to be deficient utilization of vitamin K. Synthesis of coagulation factors I mentioned will also be deficient. And the platelet function may also be further diminished. The numbers are diminished, but the platelet function can also be diminished because of the fibrinogen and fibrin degradation products. Those products will have a negative effect on platelet function. We also have delayed clearance of activated factors and anticoagulants, and there is increased fibrinogenolysis. So it's a complex situation. The whole system has gone haywire. Coagulation factors are depleted. They also get consumed. You can get a DIC in severe liver disease, and it is a very difficult situation. So we just need to support the patient, replace the coagulation factors, replace the platelets, treat the hypotension, and treat the varices. The varices can be banded, stop the bleeding, and try and salvage the patient. So in liver disease, the prothrombin time, especially when there is obstructive liver disease, the prothrombin time will be prolonged. The activated partial thromboplastin time is raised. If you are able to do a thrombin time, the thrombin time is also prolonged. And we can demonstrate increased fibrinolytic activity when there is advanced liver disease. So treatment basically is to replace the coagulation factor. So we can use fresh frozen plasma. We have another product available known as prothrombin complex concentrates, which are fairly expensive to use, but contain a number of factors in high concentration. So prothrombin complex concentrates are an option available in some of the centers. If there is no DIC, then we can give fibrinolytic inhibitors. I normally tend to avoid using fibrinolytic inhibitors in DIC because what it does, if you use fibrinolytic inhibitors, whatever fibrin is being formed, it will not be cleared. Fibrinolytic inhibitors will prevent fibrinolysis. So the fibrin tends to remain within the blood vessel, microvasculature, and will cause more end organ damage. So we would tend to avoid using fibrinolytic agents in DIC if possible, even if there is no DIC in patients with liver disease. The benefit of using it has to be weighed against the risks. And where there is obstructive liver disease, as I mentioned, it will cause vitamin K deficiency. We can give them vitamin K parenterally, IV vitamin K 10 milligrams daily for 3 days would help in minimizing the hemorrhagic tendency that we see in this disorder. So vitamin K deficiency, usually seen in neonates. Vitamin K is a fat-soluble vitamin, and it's absorbed in the small intestine. It requires bile salts for absorption, and small amounts of vitamin K are stored in the liver. And it is required for gamma carboxylation of factor 2, 7, 9, and 10. Without this carboxylation, the factors are not going to be functional. So vitamin K deficiency we see in the newborn, what we call hemorrhagic disease of the newborn. It is also seen when there is poor dietary intake and in impaired absorption due to obstructive jaundice or malabsorption syndromes. And we may see an acquired vitamin K deficiency-like state when we use anticoagulants, which are known as vitamin K antagonists like warfarin. And a similar effect is seen when we use broad-spectrum antibiotics, because it clears out some of the bacteria in the gut, which synthesize vitamin K. So we get a vitamin K-like deficiency with the prolonged use of broad-spectrum antibiotics. But more importantly, the coumarin derivatives that we use as anticoagulants, like warfarin and so forth, are vitamin K antagonists. They prevent gamma carboxylation of the vitamin K dependent factors, and they present like vitamin K deficiency. So in hemorrhagic disease of the newborn, we know that the levels of vitamin K are low at birth. It's after birth that the gut gets colonized and the bacteria in the gut start synthesizing vitamin K, and then the levels get back to normal. They usually fall at 2 to 3 days after birth, and it's more pronounced in preterm babies. So the problem is that this will cause bleeding, and there are 3 forms of this that we see: early, classic, and late. So commonly seen in the newborn. and that warrants that the newborn is supplemented with vitamin K. I think it's standard procedure, and this is what you will be doing when you rotate in the nurseries during your pediatric rotations. Early can arise because of maternal ingestion of anticonvulsants, oral anticoagulants, and anti-TB drugs, and it presents within 24 hours of birth. The classic one occurs exclusively in breastfed newborns. I think that's a wrong statement. It occurs in newborns, and thereafter, when they are being breastfed, it aggravates the vitamin K deficiency in this because they're not able to synthesize vitamin K, and the bleeding occurs 2 to 3 days after birth. The leg develops 1 month after birth, and it can be because of malabsorption or a rare condition known as biliary atresia. So there is poor absorption of vitamin K, usually due to malabsorption. But there is a rare condition where the biliary tract is not fully developed in the newborn. We call that biliary atresia. Of course, the child will be jaundiced, the liver functions will be abnormal, and it's a clinical diagnosis that we would see. And when we do the ultrasound, we can demonstrate that the biliary tree is not well developed in the newborn that is affected. So what we do normally is we give prophylactic administration of vitamin K at birth, usually 0.5 to 1 milligram intramuscularly. And if there is bleeding that has taken place, then we can give them parenteral vitamin K as well as fresh frozen plasma to control the bleeding. So some of these babies may present with hematomas as in a normal delivery, while passing out through the reproductive tract. During delivery, some may present with hematomas. Some may also occasionally have intracranial bleeding, and they would require fresh frozen plasma to replace the, to supplement the coagulation factors and to control the bleeding, as the natural mechanisms of producing the coagulation factors come into play after birth. So I'll stop there and see if there are any questions that need to be, or anything which is not clear. Now, I just want to emphasize on 2 other points which I have not captured in this lecture. One is that you can have acquired deficiency of factor 8, acquired deficiency of factor 9, and acquired deficiency of von Willebrand's disease. Now, these are not common conditions. They are rare. And they arise because there are antibodies that are produced against factor 8, factor 9, or von Willebrand's disease. So, though not very common, these conditions may arise, okay? And they are usually seen in autoimmune disorders, patients who have an autoimmune disorder. And we are able to, again, identify these antibodies, and the treatment is immunosuppressive therapy and replacement of the factor. once immunosuppressive treatment has started. The other diseases that we need to capture in this lecture, which I have not included, is acquired platelet disorders, and that is mainly immune thrombocytopenia, antibodies against the platelets, ITP. I think that will be covered separately. And the second is thrombocytopenia due to reduced production in the bone marrow, either due to the leukemias, lymphomas, myelomas, or bone marrow infiltration by other tumors, and the myeloproliferative disorders, myelofibrosis. Those are acquired hemostatic disorders due to low platelet production. So I'll just go into the chat box and see if there are any. Could you please briefly go over the pathogenesis of DIC? Okay, so let's go back to DIC. I'll just go back to the slides on top. So let me just slide off. So when it comes to DIC, disseminated intravascular coagulation, what is happening is that there is activation of the coagulation pathway, but it is low intensity. You know, the type of activation that we talk about in the hemostatic pathway, the objective of that is to form a clot and prevent blood loss. But in disseminated intravascular coagulation, there is very low intensity activation of the coagulation cascade. So we get fibrinogen converted to fibrin because thrombin is produced, converts fibrinogen to fibrin. And as you are aware, in the hemostatic pathway, the fibrin, together with the red cells, platelets, and the stabilizing factor will form a clot. But in DIC, the fibrin that is formed is removed from circulation. Okay, so as a consequence, a clot is not formed. The fibrin strands will hang around for a short period of time, and then they are cleared from circulation. They do not form a clot. Now, what happens is that the fibrin is degraded, and as a consequence of that, we get fibrin degradation products that are formed. The smallest of these fibrin degradation products are known as D-dimers. D-dimers we are able to measure in the laboratory, and it's a useful tool to tell us that the coagulation cascade has been activated. So there is a low-grade activation of the coagulation cascade. Yeah, principally it's the extrinsic pathway which is activated. Okay, and there is thrombin which is generated, which will convert fibrinogen to fibrin. And this is a continuous process. Yeah, it's going on continuously over a period of time. And as a consequence of that, the coagulation factors get consumed. They get used up. Okay, and so that is now a state of hypocoagulability. So they are at a risk of bleeding. In addition to the coagulation factors that are being consumed, the platelets also get used up. So there is thrombocytopenia. And these two, low coagulation factors plus the low platelets, bring about a very high risk situation for bleeding. Indeed, the patients will start bleeding If you cannulate them, they'll bleed from the cannula site. If you wherever we insert a needle, they'll bleed from there, bleeding from venipuncture sites, okay? And spontaneous bleeding can take place virtually anywhere in the body. In addition to that, the fibrin in the microvasculature will obstruct the blood flow, and there is end organ damage. So we get renal failure principally that can take place. So the renal functions get altered. So it's quite a multisystemic disease that takes place. Various organs get affected, and it is a life-threatening condition. The treatment is to immediately treat the cause, whether it is a severe infection, whether it's an obstetrical cause. If it's a snake bite, then you need to use the appropriate antivenom. So the first thing you have to do is identify the cause and treat the cause. And as you are treating the cause, you have to support the patient by replacing the coagulation factors, by replacing the platelets, as we try to normalize the situation. They go into renal failure. We need to support them with dialysis and correct metabolic acidosis. So it is a very intensive type of treatment that we do when a patient has DIC. So what I have, the topics that you would need to do, which I didn't capture in this lecture. Number one is that we can have acquired factor 8 deficiency, acquired hemophilia. Okay, so you can read around that, acquired hemophilia. It just presents like the congenital hemophilias. Okay, so antibodies against factor 8, acquired hemophilia A. Antibodies against factor 9 also do occur, not as common as factor 8, and that is acquired hemophilia B. And we can also have antibodies against von Willebrand's factor, causing acquired von Willebrand's disease. Yeah, these are mainly seen in autoimmune diseases. So you have antibodies against the coagulation factors. So that's what I have not covered in this lecture. I also didn't talk about platelets. Acquired hemostatic disorders, we would look at thrombocytopenia and look at the various causes, acquired causes of thrombocytopenia. So we have immune thrombocytopenia, ITP, okay, where we have antibodies against platelets, okay, and that would be that ITP on its own would form the basis of an individual lecture. Okay, it's a long topic. So ITP, immune thrombocytopenia, as a topic on its own when we are talking about acquired hemostatic disorders. That's a lecture on its own. And then the other causes of thrombocytopenia are reduced production by the bone marrow. So I talked about bone marrow failure syndromes, aplastic anemia, and the leukemias, the lymphomas, myeloma, and myelofibrosis. So those are the other topics that would need to be covered in acquired hemostasis. I think there should be a separate lecture on ITP. Yeah. Now this is a very important question. What happens in massive transfusion syndrome? So there are situations where we need to use a lot of blood in a patient. We need to replace the blood, the entire blood volume in a period of less than 24 hours. We call that a massive transfusion. So that you would see in patients who have trauma and are bleeding. Okay. We also see that sometimes in patients who are undergoing liver transplant. Okay. So in this situation, it's principally somebody who is bleeding, and we are replacing the blood volume. Now, as we replace the blood volume, we are using blood. What we have in the blood bank is usually packed cells. If there is whole blood, we would use whole blood. But what happens is that as we are replacing the blood volume, the coagulation factors get diluted out. Okay? They get diluted out, and as a consequence of that, the levels of coagulation factors appear low, and presents as a coagulation disorder. Okay, so that's what massive transfusion does, and we have to replace. Once we have replaced the entire volume, we would need to replace the coagulation factors in patients who are receiving massive blood transfusion. So we would also give them fresh frozen plasma to replace the coagulation factors, because they are losing blood. We are replacing the blood volume, but the coagulation factors get diluted. We are also using plasma expanders in these patients to try and maintain the blood pressure. And the end result is that we are diluting the coagulation factors. And because of that, they have a tendency to bleeding. It makes their bleeding worse, let's put it that way. Yeah. So massive transfusion, we need to replace the coagulation factors. We also need to give them platelets. Yeah, those are what was there in the chat box. Is there any other questions on the chat box? Yeah. So I think there's one more question. Let's see what that is. Sorry. Is newborn hemolytic disease also an acquired syndrome? Okay. Is newborn hemolytic disease? Now, I think I made a mistake this afternoon. I thought the topic was on hemolysis. I don't know. I think I read the message wrong. So we were talking about hemostasis, but is newborn hemolytic disease also an acquired syndrome? Hemolytic disease of the newborn. Yes, in my lecture, which I was going to give you, I had included hemolytic disease of the newborn as an acquired disorder, because we are dealing with antibodies that are produced by the mother to certain red cell antigens, and those antibodies cause hemolysis. So it is an acquired syndrome. It is not inherited. Yeah. So this, just to digress, yes, it is not an inherited condition. It is an acquired disorder of hemolysis. Okay, so what I would like to know from the class rep, Timur, just find out from me whether this lecture was supposed to cover ITP or not, because we would need to have a separate lecture on platelet. I would prefer to have a separate lecture on platelet disorders, acquired platelet disorders.
Correct, doctor. I'll find
okay.
out.
Find out and let me know. Yeah.
Okay.
Yep. Now there's one more question from Michelle. Why is there increased fibrinogenolysis in advanced liver disease? Yeah, this contributes also to the bleeding that we see, because the fibrin is going to get degraded faster, and therefore that makes it aggravates bleeding. Fibrinolysis, if we inhibit fibrinolysis, the fibrin will not get cleared, and where desirable, that is what we would like, especially when we are having bleeding due to injury. Yeah, but fibrinolysis, basically, you get fibrinogen, which is converted, which activates plasminogen to plasmin, and plasmin degrades fibrin. So there is increased plasmin that is generated, which is responsible for causing fibrinolysis in advanced liver disease. Okay? And again, it's a very intricate system. The hemostatic mechanism is a system which is self-controlling. You have coagulation factors which are activated, but then you have inhibitors, so it's trying to balance it out. And plasmin is generated, and that is what helps to degrade the fibrin. And unfortunately, plasmin is also cleared by the liver. So when we have liver disease, plasmin that is generated is not going to be cleared, and it is going to aggravate fibrinolysis. So it's a catch-22 situation. Coagulation factors are not produced. The things that are required for to maintain the positive and negative controls, that the whole system gets deranged. And in this case, when we talk about increased fibrinolysis, the liver is also responsible for degrading plasmin, and plasmin then is going to continue being active, and it's going to cause fibrinolysis. Yeah, good question. Okay, so class rep, you tell me about the platelets, if the lecture has not been covered, ITP, and bone marrow failure syndromes. Yeah. Then you let me know, then we can prepare. I can prepare a lecture on that. Okay.
Yes, doctor.
Yeah, good.
Thank you so much.
Okay.
All right.
Recording stopped.